Now this is what we've been all waiting for. Everything you need to know about Obamacare in 7 slides. John?
Hi, everybody. I'm John Canham Clyne. I'm the Deputy Research Director for Unite Here International Union. I understand I have 8 minutes, so in the next 8 minutes I'm going to try to do 3 things. 1, take you through Obamacare in 7 slides. 2, that I'm going to brag a little bit about our union because I think our union is just great. And then 3, focus on what we actually need to do to deal with the current situation. I do actually want to run the slides if we've got the clicker over there.
Let me see if I can do it. Let's see where it happens. Can I do it like this?
It's the bottom button.
Bottom button?
Right.
There we go.
So first I want to just start off with the basic background. For 70 years, the health insurance industry failed to do its job, which is to cover everybody in the country, particularly in the individual insurance market. Congress and the President chose a particular strategy to fix that. That is, we're going to throw money at the people who failed to do the job in the past. That's not, you can laugh, it's a legitimate strategy, right? In particular because they had so much money and so much power, taking them on politically seemed very difficult. So the thought was, all right, let's subsidize the health insurance industry to see if they'll actually cover people. That's the experiment that we're in. It's an enormously expensive one. As you see on the screen, we're talking about $1.25 trillion over a 10-year period. It's a stunning, astonishing amount of money. And you know, the health insurance industry is really on the spot to figure out if they're actually going to be able to do it. Can we click the next? Let's be clear also who's paying for this. Towards the end of last year, Brookings released a study that was hyped by the administration and other folks as proving that the Affordable Care Act was going to take a big bite out of inequality in the United States of America. Well, if you actually look at what's happening, while the bottom 2 income deciles are going to have a significant income increase, the Affordable Care Act, again, by a supportive institution and researchers who believe this is an improvement in inequality, right? The biggest bites of the biggest drops in income are going to come in the next 2 income deciles. So, and you're talking about those are families that are circled on the left-hand side of this slide. Those are families between $20,000 and $38,000 worth of family income. By the way, those are our members and our future members. Unite Here represents workers in low-wage industries, in hospitality, institutional food service, and gaming. Right? So our members are being asked to pay for our future members, who are poorer than our current members, right? In order to get health care. It's not progressive taxation, as Rand was saying earlier. It's not anything that we would look at as being wise fiscal policy. Next slide, please. The biggest challenge, I think, actually in the law is that virtually all of the cost control strategies are utterly unproven. And I think that's being generous. The 2 big areas that you'll hear the most about are the attempt to have affordable, accountable care organizations take on health insurance risks even while they're providers, and then doing so and structuring reimbursements around the notion of outcomes and quality and performance. Right? There are 2 problems with that. First, for the first strategy, we tried it. There's a reason that everybody in this room thinks that HMOs and managed care are a dirty word. There's a reason that states around the entire country spend a lot of time passing patients' Bill of Rights, trying to get rid of drive-through deliveries. That's because there was a major private sector experiment with this kind of reimbursement in the 80s and 90s, and it drove the country crazy. I'm not saying it's going to fail this time, but folks like Dolores, folks like our funds are going to have to do a phenomenal amount of work to ensure that that kind of reimbursement and that kind of payment goes towards controlling costs and doesn't get ripped out of the hides of patients the way it did in the 80s and 90s. And on the other strategy, if you talk to anybody who's actually doing this, there are a handful of conditions that we really understand technically and technologically, where you could structure payment to really press providers to take care of people well. There's a whole universe of things that we have absolutely no idea what real outcomes look like, what the right interim benchmarks are to peg payment for. So these are really unproven strategies. Next clip, please. There was one proven cost control strategy in the bill, and that was to close an absolutely scandalous loophole by which the health insurance industry was receiving billions and billions of dollars per year in excess Medicare Advantage payments. Medicare Advantage is the Medicare managed care program. It's an open secret in Washington that we've been throwing money at them, and that actually fee-for-service Medicare is far more efficient than those plans are. The ACA was going to close that and help use that money to finance the subsidies. Click, please. Predictably, they just gave it back. And one of the amazing things about the last 3 or 4 years is the degree to which you're just seeing these massive givebacks on the positive sides of the law, and no attempt to work to reach out and fix stuff for us. And we'll talk about that in a second. I'm a strong supporter of the positive provisions of this law, but I also think that the people in this room need to be really clear-eyed about what's going to happen to us. Next slide, please. This is well known. The administration continues to deny that there's any real data showing that there are impacts on hours worked and on other cost strategies. If you look up there, they're already doing it. Right? This is data from AFLAC surveys of employers. They are cutting hours. They are cutting benefits. It is a natural reaction, by employers to the law. And so we're in real trouble. I will tell you, our union is mounting a huge campaign right now that we're going to need everybody's help here. Sodexo has decided that because they are a subcontractor, that the rules that apply to academic institutions don't apply to them. So what Sodexo said is, we're going to calculate whether or not you're full-time based on a 12-month look-back, right? Schools are not allowed to do that because everybody knows if you're a full-time school worker, you don't work in the summer, right? Sodexo says we're a contractor. The rules that apply to academic institutions don't apply to us, and they've now wiped out benefits for around 10,000 workers without doing anything except just changing their accounting. They said, you're averaging less than 30 hours a week because you may be working full-time during the school year, you're not working during the summer. Bam! And not only is that health benefits, it's also sick leave. Can you imagine? Food service workers who feed food to our children are being forced to come to work sick. That's a brilliant idea, right? Vacation, all of those things. So our union is going to be running a campaign on this question. We'd really love everybody's help because this is vital to both our organized and unorganized members. Next slide, please. Good news, this is actually great news. 8 million people have signed up. People are going to get coverage. Right? I don't want to diminish or deny that. That's critical. That's vital. And as I said, in many cases in our industries, it's the family members of the people that we actually represent in hotels and casinos and food service. Next step. Next slide, please. But let's face it, right? As that second slide shows, the cost, the payment for this is coming out of the pockets of our members, right? So if you take a look at the difference between what it costs to get healthcare on the exchanges out of pocket and what it costs our members, it's massive. Our members are looking at a $2, $3, $5 an hour increase, or we're looking at going to the bargaining table and trying to negotiate major cash payments to support our members. Otherwise, if folks get pushed onto the exchanges, which I believe they will, they're in real trouble. The other thing is, this bill has been fixed for everybody. And not only has it been fixed, and I want to take a little bit of issue with Karen here, the issue is A, not the Republicans, and B, not legislation. The issue is the Obama administration and the Democrats. And the reason I say that is the Obama administration has trampled the statute, trampled it for everybody but our members. Right? Those deadlines that they've moved, they were hard deadlines in the statute. They said, forget it, we're just not going to meet them. Right? If it's okay to do that, they should be pushing to stretch the law as much as possible through regulation to help us out. Next slide, please. I don't want to go into detail. Most folks know the problems that we face, the gap between what our plans cost and what the penalties are, the fact that we're in a box as self-insured Taft-Hartley plans, which means we can't compete on the exchanges for subsidies. All of those issues, I think, are well understood by folks in this room, but we call it the 5-year Taft-Hartley death spiral. It is, particularly if the excise tax does not go away, we're in enormous trouble. Next. I got 1 minute left, so I'm going to brag about our union and tell you what we should do. Click again. I was at an event about 2 weeks ago where we opened a new healthcare center in Atlantic City for our members. Arnie Milstein introduced Betsy Gilbertson, who is our national healthcare guru. Arnie is the leader of the healthcare quality movement. And just to brag, he said that we're the most sophisticated payer in the country. We're doing everything. We're building stuff.
I am. Arnie told me I.
You know what? We called him out. We caught Arnie. Like, this is worth a trip just to catch him on a line. But like GIC, we're doing everything we can. We're restructuring delivery systems. We're talking to our members. Local 26 has done an amazing job going after our members and saying, look, guys, we're going to have to narrow our networks. It's just a reality. In Las Vegas, we run our own pharmacy. We run our own 24-hour pediatric urgent care center. We're doing everything that the gurus tell us. It's not even close to enough. It's just not close to enough. We're going to have to tackle these cost problems politically. Click twice, please. So just to finish, one, at the national level, we have to press the president and the Democrats. There are all sorts of tools in this law that the president and the agencies could use if the political will was there to do it. And that means that we can't go into our usual conversations with our Democratic friends and say, hey, how you doing? How are the kids? We have to start making our friends uncomfortable about the need to help us out. That's a very difficult thing to do in an election year. Yes, the other side are lunatics. I get that. But we actually have to make our friends uncomfortable. And at the state level, we have to start digging in on the things that Dolores was talking about. In addition to pressing as purchasers of healthcare, there, I think, is a wide open field for things like transparency on insurance rates, transparency on provider rates. Heck, forget it. Let's just regulate hospital rates, period, altogether. Right? There are opportunities for state attorneys general to take real strong antitrust measures. In New Haven, we face the same thing that you guys do with Yale New Haven Hospital. It's a burgeoning monopoly, vertically and horizontally. They're taking over all the physician practices. On questions, I'll tell a little story about that, where we've actually just started this process of trying to regulate facility fees. People know when a hospital buys a doctor's office, all of a sudden that doctor's office becomes part of an outpatient department, and they start billing you as though the same care you're getting from your doc is happening in a hospital. Right? So we're starting the process of trying to regulate that in Connecticut because it's destroying all of our reform attempts. Right? Just as patients are finally starting to get the message, don't go to the hospital, hospital prices get applied to doctor's offices, so you're not actually saving the money that you want to do. So there's a lot that we can do, but it requires a determination to fight and a determination to make our friends uncomfortable and real focus and coalition building among purchasers, among unions, among willing employers, and among the advocacy community to take on at the state level these cost issues. This bill will not control costs. If we're going to do it, we're going to have to do it on our own at the state level.